growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, this is Dr. Steve Rasner, and you are tuned in to The Lionhearted. Thanks for joining me. I've been doing these podcasts, as you know, for about a year. And I keep changing the format on purpose to try to keep it exciting. And actually, I'm trying different formulas to see what appeals to you, my audience, the most. But my only agenda here, as you would know by now, is to give you a shortcut to enjoying what I have from dentistry, and that is a pretty predominant fee-for-service practice, enabling me to do challenging procedures every day, including today, and to let you know that it doesn't have to be a thought of profession as a wrong career choice, and you're stuck in an associateship you don't like, or working for a large corporation that doesn't seem to value you and get you. That's why I'm here. So the change in format tonight, which hopefully I'll stick to, is I'm going to give you a couple key pearls about how to run your practice, in my opinion. And then I'm going to give you my case of the day. And that's the change that I'm going to keep trying to do for a while. Meaning, I think the most important thing I can talk about on this program is case acceptance, because that's what drives what you do every day. If you don't get case acceptance, you're doing one-tooth dentistry. So, and I'm also trying to do these, unlike I did for several months, after work. So if I sound a little, my voice is a little bit gone, that's probably why. Because I've been screaming all day at the office. No, that's not true. But I do feel like my voice isn't quite as strong. By the way, as I always tell you in the beginning, you can email me. I want you to email me. I sent out a package today to a dentist for free of materials from somewhere in Texas that had approached me with an email just last week. Some things he wanted in particular. I have an agenda of trying to help my colleagues. So you can reach me at my name, Dr. Rasner, D-R-R-A-S-N-E-R at AOL. And if you want to know where I'm speaking, or you want to attend one of my courses, which are filling up very rapidly, those of you interested in surgery, you would look out on the Rasner Institute, R-A-S-N-E-R, institute.com, and it'll tell you when the courses are in my office or on the road. By the way, would there be any interest if I went on the road and did a whole day of this, like practice management suggestions for my colleagues? I don't know. But I'm just throwing it out there to you. You can write to me and let me know. So let's get to it. What do I want to talk about tonight? I'm going to talk about two brief career type of suggestions of how you run your practice, how to avoid a problem, and I'll also talk about the case of the week. And a lot of that I'm going to do, you're going to have to close your eyes unless you're driving and visualize what I'm telling you. I might get Beth to be able to pop up the x-ray for me, Beth, if you can do that. And so my colleagues who watch this, who can have a better idea what I'm talking about. Okay. So today's subject, and it's a pretty easy one for me, is broken appointments. How do you prevent them, and what do you do about them? So I have about 5 points I want to make. Ready? Because listen, this is what I always used to say to my staff and what I used to say to my audiences. You know what we share in common? We have a time-intensive occupation to earn the money we earn. We have 8 to 10 hours a day to use our two hands. And I always recognize that. I recognize that very early. So what you need to do is minimize the waste of time that can possibly occur. So here's what you do with broken appointments. Number one, you're going to hate me for this. don't charge for them. No, don't charge $25, don't charge $50. That is a ridiculous reaction to a broken appointment. All you will do is cause negative will in your community. People are much more inclined to talk bad about you than they are good about you. Making one person mad gets out there a lot faster than making 10 people happy. So look, here's how you look at a broken appointment. You look at it as a breakdown of your system. It failed. That's the end of the story. Learn from it and change it going forward, as I'm going to show you. So this is how you prevent it. The number one way to prevent it, if you haven't done this yet, and you've heard me talk a lot about this, is try to incorporate as soon as you can the action of getting paid up front by your patients for whatever services you're going to do for them. And I'm talking about hygiene. Of course, that's getting paid as it happens anyway. I'm talking when you present a treatment plan, your expectation should be that you will get paid that visit. If you're not sure how that works, go back to my earlier podcast and review it. They're only like 25 minutes. And that's not because I'm trying to fill my bank account. It's two reasons why I think you should get paid up front. One is you have a much, much greater chance of them completing the job, of doing the work. If you haven't heard me say it before, you'll hear me say it now. How many of you, I can hold my hand up, have prepped a premolar? It was supposed to cost the patient $1,000. They only had $400. They'd pay you the balance at the insert. You take the impression, you make a nice temp, and a month later, you kind of forget they were ever in the office. And the month turns into 18 months, and they call the office because the temp fell out. And they come back in the office. Thank God you still have the case in the lab. You bring out your crown and you check everything, and you take your Explorer, and your Explorer has a magical ability now to go right through the prep because it's all mush underneath. Now what do? Now you're lost. You either have to eat the root canal, which some of you would do, or worse, maybe it's an extraction. And you know what? You never win that way. There's just not enough people that are going to tell the truth the way it was. I don't know many. I wish there wasn't that way in humanity, but it is. So getting paid up front absolutely decreases broken appointments. And if you want your own proof for it, watch what happens in the next 2 weeks when you have some broken appointments. Go to your front desk and ask if that patient was due to make a payment. I don't care if it was $400 and they were having 3 fillings done or whatever the fee would have been. Even in my office, as recently as last week on one of my associates, there was a 2-hour broken appointment to start the day, by the way. I can assure you I wasn't too happy. And first question I ask is, I assumed. I said, how much were they supposed to bring in? And sure enough, my staff said, how did you know that? I said, how did I know that? Listen to my podcast. I always tell you that. And how you can make that patient the first patient of the day is a tremendous mistake. So, broken appointments, don't charge for them. Number 2, try to get paid up front. If you don't know how to do it, write to Michelle, Michele, 1L, at pearlsmiles.com. That's Michelle, my new patient coordinator, my financial coordinator, who's been with me 39 years. I'm not telling you it's exactly every word that comes out of her mouth. It's more of a mindset of us expecting that's just how we do business because it's a better way to do business. And it is. It's better for the patient, actually. Listen, they can either afford the care or they can't. And I'm not trying to be callous about it. I'm trying to kind of, in a odd way right now, I'm trying to protect the patient also. It doesn't do the patient any good to put a portion of the money down to get started and hope they can find the rest down the road. You know, I just think everybody wins and everybody loses if you have an opposite approach. If you break it down into extended payments over a period of time, many times that's not going to work out. It didn't work out for me. Also, Any patients with a history of a broken appointment, I don't care if they've been to you 10 times and they've broken one appointment, they should never get the first appointment. Now, I know scheduling managers that are listening to this right now say easy for me to say, and I know I'm not saying it's easy. I'm just telling you, you look at your broken appointments, almost always it'll be somebody with a history of a broken appointment. So a good protocol, for example, is we never try to give a patient to start the day of hygiene. Somebody that's had a broken appointment won't get that appointment. We don't say it that way. We just somehow get around it, and we've been doing it for 30 plus years, that the first available appointment we have for you, Mr. Smith, is 10 o'clock the week of whatever week it is. They're not getting the first appointment. Because this is how it goes. People that break appointments will always break a second appointment. And others that don't break appointments, like myself, for example, will do anything to keep their word. If they break their arm, they'll go to the hospital after they do your appointment. I'm not kidding. There are people who think like that. That's who you want. Now look, you're going to have to sometimes do Hail Marys. I get it. You know, you're trying to fill the schedule, and oh my God, all you have is Mr. Green, and he's broken a couple before. I don't know. I think you're kidding yourself. I'd rather tell the hygienist to come an hour late. And the reason it's so important is because hygiene is not the most profitable center at all of your office, but it's a key center of your office because it's where you get a lot of your work. And it is a predictable center of profit, meaning if you fill the hygiene schedules with 7 to 8 patients a day, you are positively going to make some level of profit 7 to 8 times that day. Do you make a fortune? Absolutely not. You don't make a fortune. It's not even what hygiene's for. Hygiene's to maintain your work. Hygiene is to maintain the nucleus and the base that I want you to grow. That's what it's for. But by the same token, you don't want to wave the white flag and put a patient that has a history of broken appointments in the first appointment. You're better off if you can't fill it with somebody that's reliable. And you know, if you're early in your career, it's harder to do what I'm telling you. I've been in this a long time, but this philosophy that I'm sharing with you has gone on for a long time. I've always been irked about people breaking appointments in my office. So for that reason, and this one's going to floor you, I never allowed, when we were confirming hygiene, I never allowed the person confirming that to leave a message on a machine or leave a message with a kid, which used to, and because the reason I'm like that is because we always had broken appointments based on those experiences. I left a message, Dr. Rasner. You did? Who did you just speak to? And we would find out it was like a 9-year-old. So, look, everybody has their own thing that's important to them. I know you have 8 to 10 hours a day to put this machine together that we keep talking about that needs to be well-oiled. Being well-oiled means there's people in your chairs. It's interesting, you haven't heard me talk about broken appointments with me to start my day, or broken appointments by me almost, period. And you know what? It absolutely almost never happens. Do you know why? Because I get paid up front. When I owe them, they show up. That's the way it is. So that's your lesson in broken appointments. And so let's talk for a few minutes about the case of the day, which I'll see. Let me know if you hate it and say, hey, that wasn't the greatest idea, Raz. You can be nice about it, I hope. One more tip I want to talk about before I get to the case of the day. Taking courses, okay? I guess I'll never get hired by another big convention after saying this to you. But this is what my advice is to you. When you're at a convention, the ADA convention, the AGD, and you're surrounded by all these exhibitors, try not to purchase the day or the weekend of the exhibition. I know they have a course special or whatever they're telling you. 2 reasons you don't do that. One is I believe that special will be there a week after if you still really want it. And number two, make sure that you do really want it, what they're selling. It is, and if you want some of, why am I sharing this with you? You can walk up in my attic with me and look at my $50,000 laser. Not that I'm against lasers, but this is from 15 years ago. Next to that, you'll see one of the original piezo machines, which I have total respect for. And by the way, I do have a new model of a piezo in my office, but that was 10 years after not using the first one. So think it out. I mean, I am as guilty as anybody could be of doing what I'm telling you. The other thing is this. When you go to invest serious money in courses, be sure that it applies to your community and skill set. So let me give you an example. And boy, I hope this doesn't come off wrong. I would say, like, if you're in implant dentistry, certainly learning how to do sinus lifts is a level that I would absolutely think you need to do if you're going to go advanced and you're going to be in there a long time. But I took courses in that many times that I don't regret. Soft tissue around implants is another. If you're doing implants, you have to know this stuff. Do you have to grow vertical and horizontal bone to be an implantologist? I've been trained to do those things, and I'm okay at them probably. I'm talking about ramus grafts and splitting ramus grafts into membranes of thin bone and things like this. A skill that's, number one, when you're starting to talk about those kind of procedures, ramus grafts, vertical, horizontal augmentation, I don't think that I've done it many times. I think you need at that point to go from maybe oral sedation, management of the patient, to IV sedation. Because here's what happens. If you press the limit of the procedure and the patient's not as compliant as you need them to be, because maybe they're feeling something, you get me? It immediately diminishes your skill as a surgeon. If you were normally a 9, you become a 6, because it's hard to do excellent surgery on a patient that you think's feeling it. So think about what I'm saying. I'm telling you, before you run out and spend $5,000 on, and I know this is advanced for some of you listening, make sure that you think that is something you can actually incorporate in your repertoire of services that people will pay for in your community. So let me get to case of the day. Patient comes into my office last Wednesday. 76-year-old female. I'm not saying she looked like she was out of Vogue, but she certainly was dressed better than a lot of patients that come in. So she cared about how she looked. Get the drift. And the reason she came to the office is she had slivered off a significant portion of the lingual aspect of her upper left cuspid, number 11. And I mean, significantly slivered it off. It was restorable, salvageable, and needed root canal. It did not hurt her though. And so I want you to picture what I'm about to share with you. She didn't have all of her teeth. She had most of her teeth. She had an acquired class 1 occlusion. Some teeth had drifted. She didn't have any TMJ muscle or joint dysfunction that I could detect. Didn't have perio. I mean, she had gingivitis because of poor dentistry, but she didn't have any bone loss. And I go through my whole spiel, and here's what she has. Picture this in your head. We'll deal with the area of immediate concern. So numbers 5, 6, and 7 on her were okay. Number 11's her chief complaint. Number 8 had a history of root canal and a crown, a head-like crown, got ugly crown. It doesn't matter. That's not the reason, but it had recurrent decay. Clear recurrent decay that a first-year dental student could see. Number 9 had about a 10 surface composite on it with recurrent decay. Number 11 had the slivered lingual off, no root canal. Number 12 had a history of root canal, a crown, and recurrent decay, and not a great crown to root ratio. She was a type 2 diabetic. She had a HbA1c test of over 7 point something. She was not a good candidate for implants in my office. It didn't even matter. You've heard how I approach patients. I gave her my whole spiel, and the spiel about what to do when. I told you that I tell patients that I've learned an amazing amount of dentistry in my lifetime. I'm just so on board of what I do every day. So I take 1,000,000 courses. That's how I relate it to the patient. And I tell them that I've learned a lot of amazing things, how to sedate them, how to take their tooth out without putting my knee on their chest. And you'll find all these things, guys, in earlier podcasts. But I tell them what I learned the most is called what to do when, which means how do I know what I should recommend for you? And how do you even know that that's correct? And I said, I never use the word comprehensive exam, but I say I do it by looking at 5 things on you. And if I look at those 5 aspects, I know I'm going to give you the right advice. So I look at their perio. I look at all of their teeth. I look at their missing teeth and see if that's something I have to deal with right now. I look at their occlusion and I look at their aesthetics. So I go through the whole thing and I tell her what I thought she needed, which was I thought she needed to crown 8 through 12 and splint them. I hate splinting crowns, but if she wants to keep those teeth, that one tooth, that's what she has to do. Because guess what? When I finished, she said, I just want you to do the one tooth. Just like that. And I told her the one tooth already needed root canal and a crown. So this is what I said. I swear. And this is the takeaway. And I don't do this all the time. But maybe the more of these various scenarios you hear, it'll help shape you. Just like watching a tennis person on YouTube, their backhand or their forehand or their serve, maybe that'll affect your serve or backhand or forehand. I said, you know what? I don't remember her name right this second. I said, I really like you, and I'd love to be your dentist. But if I'm not, we can still be friends. Here's the deal. I draw lines in the sand on cases that come to me, and the line is what I think I have to do that will allow this to work a reasonable amount of time in your eyes, not just mine. And the only way I can do that with you is if you do the following. This is after she told me, after I already told her what I recommended her to do, then she told me, can I just do the one tooth? And I said, it is not even about like the money. I'd rather you not have to invest a lot of money. But I'm absolutely in my hands not touching this case unless you, and I held a mirror up, by the way, also. Literally a mirror that you would buy from a drugstore. So I have them in all my rooms. And I pointed to where I'm going to go. Long story short, it was a $10,000, around $10,000 case. And she accepted, and she's in the schedule next week. Does it always work that way? It doesn't. But the principle I'm giving you is don't hesitate to dissuade a patient from a treatment plan if it isn't the right case. Don't put, not in my world, don't put 2 implants on the mandible with 2 locators. I mean, I guess if they're 90, I don't want to give you such random possibilities. I always use 3 implants in case one of them goes down. And it's just what I've been doing, and not many of them fail anyway. But I think the point I'm making to you, better yet, don't make a new denture on an atrophic mandible when you know implants is the right treatment, just to have them say yes and get some kind of case. That would be bad dentistry to me. I hope this helped you guys. I hope somebody, let me know if you like this last part. And if you don't, I'll just let it fade. Until then, I'll see you next week on The Lionhearted. Have a great week, and I look forward to talking to you soon.